Sometimes the most important things happen in the most incongruous of places, and here we are at the International Coffee Organisation for what I think actually will be seen as one of the most significant moments in the dramatic transformation of services that is going to happen in the NHS as a result of the sharing of information in a practical and responsible way. And I think this is a really exciting moment, and the first thing I want to do is to thank Dame Fiona and all her team for an absolutely excellent report, which I think has got to the heart of the issues that we face. I'm very conscious on these occasions of what Ronald Reagan said when he said the 9 most frightening words in the English language are "I'm from the government and I'm here to help." So I think it's important, particularly when it comes to information governance, to have proper humility, because there are some very difficult and complex issues that lie behind this. But I just want to say that if you look at the big challenges facing the health service with an ageing society, things like the challenge of A&E departments that I was talking about yesterday, the problem of joined up services, particularly for older people with complex multiple long-term conditions, the issues of patient safety and compassionate care that came into the Francis Review, none of those issues are going to be resolved unless we take a much more ambitious and enlightened view as to the power of information. I'll give you an example. A few weeks ago I was in the A&E department at Watford, and they admitted a lady there when I was there with late-stage dementia from a dementia care home. And I was completely shocked to see that they knew absolutely nothing about her. So this lady had arrived. She wasn't able to speak. She had bruises all over her face. But they didn't know, for example, whether that was her normal state, not to be able to speak, or whether in fact it was as a result of her fall. They didn't have her medical history, her medication, anything like that. And that simply cannot be in people's interests, to have those gaps in the flow of information. I think most NHS users would be astonished that that information doesn't already flow around the system. The fact that in George Eliot Hospital, where I was last week, one of the nurses told me that on the afternoon shift you will generally spend 2/3 of your time doing paperwork to admit people in, and the fact that in many hospitals the IT systems aren't even linked within a hospital, let alone between hospitals and other parts of the health economy. And that's, I'm afraid, a fairly normal situation across the country. The fact that 11 people died last year in the NHS from being given the wrong medication. When we do have hospitals, and I've been to one in Airedale in Yorkshire, where they have completely integrated primary and secondary care, so that if you're admitted to A&E at 4 o'clock in the afternoon, the A&E department can actually see what your GP prescribed you at 10 o'clock that morning. And that is incredibly important information, particularly for patients who are not able or don't find it easy to speak for themselves. So this is a really important part of the compassionate care agenda, the safety agenda, the integration agenda. And I think what Dame Fiona and her team have done is created the intellectual framework through which we can approach this. And I think there are two things that really lie at the heart of this. The first is to remove a lot of the misunderstandings. I think throughout many parts of the NHS there has been an attitude of caution towards information sharing based on a fear of what the law might be, but without actually understanding what the law really is, and also what people's obligations should be in the interests of patients. And I think that a lot of those myths will be dispelled by this very good report. And I think the training that Dame Fiona talked about this morning is going to be a very important part of that. But at the same time, and I think this is also something you talked about very wisely just now, we need to have in place the proper safeguards so that the public are confident that the information is being shared with their consent and in their interests. And that's why I have agreed that GPs will not share information about people's what's on people's GP record with the Health and Care Information Centre if people object. There will be some overrides, but only in very clear situations like a public health emergency or a life and death situation or child abuse. But these are the kind of overrides that people would expect. But essentially, people will have a veto on that information being shared in the wider system. And I think it's important to do that because we need to give people confidence that they are in charge of their own medical record and they decide who sees it. But if we give them that confidence, actually what we'll find is that the vast majority of people, if they are confident that it's being used responsibly and in their interests, will want it to be shared. And Airedale Hospital told me, I asked them, you know, how does consent work? And they said it's extremely simple. When someone comes into A&E, we ask their permission. Can we access your medical record from your GP? And no one has ever said no, because it's clearly in their interest to do so. And I said, well, what happens when someone is unconscious? And they said, well, in that situation, we have an override. This is you know, something that doctors are completely used to anyway. They can operate on people without their consent if it's a life or death situation, if it's in the patient's interest. And all that happens is that it's marked on the record. This record was accessed without this patient's consent in their best interest, and it's signed off by a doctor. So there's complete transparency, everyone knows where they stand, and the patient's best interest is looked after. And I think that's all the public want in this, and I think we can get there. But I think we do need to move the centre of gravity away from not sharing information to sharing information with proper safeguards. I have asked NHS England as part of the mandate, which is a crucial part of the new structure, to ensure that everyone can access their own GP records online by 2015. So that's going to be a very important first step. And I've also said that I would like the NHS to go paperless by 2018, which my civil servants described in a very Sir Humphrey-like way as a brave thing to do. A courageous thing to do indeed. But the truth is, I think, I mean, we can learn a great deal from the problems that the last government had with Connecting for Health. But I think we should also recognise that the climate has changed, and people now understand how technology is transforming their daily lives. They're doing their Christmas shopping online, they're doing their banking online, they're buying their air tickets online, and I think there is an understanding of how technology can be a huge force for good, and what we have to do is to find a sensible, responsible way with proper safeguards of allowing this to be taken forward, and I think that's what Dame Fiona has allowed us to do. Thank you very much.
Right then, have we got any questions? Or if you'd like to say who you are and who you'd like your question addressed to, that would be helpful. So we'll start off here. Oh, you might have to shout because you've no microphone.
I can shout, no problem. Roger Goss, Co-Director Patient Concern. When I read the Daily Beast, page 17 today, I might, if I was uninformed, think problem solved. But the reality, why don't you as minister, I'm addressing minister, tell the public that if you want NHS care, then the deal is you, NHS England, and Uncle Tom Copley and all, can use your medical data, often identifiable, in whatever way they think is in the patient's best interests. And the only recourse a patient has, ultimately, is to opt out of NHS care and try and find it somewhere else.
Thank you.
Well, there are always outriders in these debates. I think the NHS belongs to those people. I don't think it's for me to tell people that they are not going to be allowed to access NHS care unless it's on terms which are decided by someone else. I think the point is we have to earn the trust of the public in this, and that means that they have to give their consent to the sharing of data. But perhaps I'm slightly different to you, is I'm very optimistic we can get that consent. I mean, the hospital in Yorkshire I was talking about, they haven't had anyone who said they don't want the A&E department to be able to access their GP record. So I think if it's done in a sensible way, people will give that consent. But I also think we've got to be careful not to scare people that there's going to be a huge database that anyone can access their information without their permission, because this is very, very private information, and they need to know there are proper safeguards in place.
I think over the last few years things have moved on enormously, and that there was a time when shared passwords was commonplace across the NHS, so you didn't have the control of who was actually looking at what. And I think if we take forward the guidance now that the strict monitoring and auditing has to be achieved, that means that shared passwords are a thing of the past. You've got to be responsible for what you look at, and you will be held accountable for that as well. And I think under that kind of guise, the patients will have more, I think, more confidence that we're treating their data more sensitively. And if you'd like to say who you are and who, yeah.
Randy Ramesh from The Guardian. Can I ask Jeremy two parts? One is a clearing up exercise, really. In the report, there's a line about GP records or hospital records being accessible within a decade. You mentioned the 2015. I just want to clear up, are those two things, do they refer to the same thing? Are we still looking at 2015, or is there some element of slippage built in? And just secondly, I note the NHS Commissioning Board was not backed in its proposal for a consent deal. There has been some worries about an EU directive, a data protection regulation, where the amendments put down for exempting medical data, which seem to do the same thing. That's the argument from the campaigners. Could you just tell me about your concerns about a backdoor entry via Europe for something the Caldicott report seems to be knocking back in the first place?
Yeah, I mean, first of all, there's no slippage. I think Fiona might be rightly recognising this is a very big challenge to give people access to their GP record, but this is an absolutely clear commitment in the mandate that this ability to access your GP record will be by 2015. I think the only thing I would say is that it won't be a complete medical record by 2015. What we want in the end is a record that isn't just what's happened at your GP surgery, but what's happened in any acute episodes that you've had, and what's happened in the social care system, and that will be a bigger process and will take longer than 2015, but no slippage in that. With respect to exemptions, I mean, I'm very clear that I have the power, or NHS England has the power, to give guidance to GPs about whether or not people's personal GP records are shared with the NHS Health and Care Information Centre, and the guidance that we will be giving GPs is that if people ask for that record not to be shared, then it won't be.
Can I just clarify on that point? When you talk about that aspect of it, that is sharing information for secondary uses, not for direct patient care.
No. If people ask for their information not to go beyond the GP surgery, then GPs will respect that.
Okay, thank you. Question at the front here.
Following on from that question. Thank you. Following on from that question, on the issue of consent, obviously there are people that have already opted out of having their records shared. What happens with those existing consent?
We will respect them.
Okay, can you elaborate on that, please?
Well, people normally like politicians to give a straight answer.
Well, certainly. But just to be clear, those privacy settings won't be wiped out. They won't be expected to opt out of the new system that you're now putting in place.
Well, we're not going to cancel the opting out that's already happened. There may be a process of recontacting people to explain the new arrangements, and that's a detail which we'll work through in operational terms. But you know, we will respect people who have already said they wish to opt out of any data sharing.
Okay, thank you.
I'm Christine Blanchard. I'm a medical director and Caldicott Guardian. My experience as a practicing clinician is actually that patients' expectations is that their information will be shared, but their expectations in a way are outstripping the technology available. So whilst we're all working on local solutions to share information electronically with our local GP practices, patients are much more mobile than that, and they expect when they turn up in the north of England or in Cornwall to have medical treatment, their information will be shared across the country. Now, I'm not aware of any plans to put any sort of national infrastructure in place to allow that to happen.
Well, we absolutely do want that to happen, and we're working very hard to deliver that. But what we've learned from the problems of the Connecting the Health programme is that if you try and construct a programme like that nationally, I mean, if 15 years ago the Minister for Technology had said, I'm going to put together a strategy that will mean that someone in Yorkshire could email someone in Cornwall, and I'm going to develop the protocols to do this. You know, actually what would have happened is we'd have never ended up being able to email each other. And what we've learned in technology is the way that these things work is by locally driven solutions with common frameworks, so that you set up a system in a town or a county where you would get initially perhaps primary care and secondary care talking to each other, then building in social care, but using protocols that mean that information could be shared more widely. So a bottom-up process we think will be far more likely to deliver that in the end. But I'm still going for 2018.
Another question over there. You might need to find your way to a microphone and press the button.
Sorry. Chris Stray, Northumbria Healthcare. You mentioned the example of Airedale Hospital, I think, in Yorkshire. I believe in Yorkshire there's only one system used by the GPs, which facilitates the communication greatly. Now, in our area, we are desperately trying to achieve this sort of communication, which we call vertical integration. But the problem is that the software companies who provide the information often don't cooperate to a degree that we would like them to cooperate. And I just wondered whether you are in a position, or you can promise us that you will impose or maybe encourage companies to work together a little more if they want to provide us with technology for the healthcare sector.
Well, I think we are doing a great deal on that front. I do recognise the technological challenges involved, and you know, this isn't going to be an easy process, but it's absolutely essential in terms of patient care and patient safety that we crack this. And the signals that, you know, that I'm giving and that NHS England are giving are that through CCGs, you know, proper responsible sharing of information will be an intrinsic part of modern NHS healthcare going forward. And so I think what we'll find is that this becomes one of the ways that we judge the success of the local healthcare economy. I should also make another point, which is that there are huge costs that can be saved by getting this right. And in a period where financial resources are very scarce, I think this is something that hospitals and CCGs and GP surgeries are going to want to be looking at. The GPs who spent hours chasing up appointments and trying to get information about what someone's diagnosis was when they were referred on, that kind of thing costs a huge amount. And so I think what we'll see in the next few years is a real change in the energy being put into this to crack it.
I think also that we tend to work in silos, don't we, in the NHS, and we have a very clear distinction between primary care and hospitals, and the savings of putting in such technology across all the patch, the savings will be in primary care. When the patient comes in and says, I've got an orthopaedic appointment, I don't know when it is, for the secretary in the practice to be able to have a look at that appointment in the hospital will save the practice time. The difficulty is, at the macroeconomics, we're saving lots of money, and in the silo, we've got to make sure that whatever we spend is measured across the whole enterprise, not just within that silo. A question there, and then a question behind me. Yes.
Hello, James Ilman from Health Service Journal. Question for both of you, really. Talking about the 2018 deadline for records across the entire health and social care system, in the report there's a clear warning there that if there isn't a clear plan for implementation, that's not going to happen. Do you both feel that at the moment there is a clear plan, or I mean, it feels at the moment that there's a vague plan and some vague ambitions, but is there not the need perhaps for some more detail, some more incentives to drive the agenda forward in a bit more of a proactive way?
Let me arrange for you to have a long discussion with my colleague Tim Kelsey at NHS England, who will tell you there is an extremely detailed plan, so detailed in fact that I can't get my head around it because it's got so much information in it. But there's a very, very big plan to do this. We're not underestimating the challenges, but I think we are, very conscious of what I was saying earlier, that if this is a top-down plan that's imposed from the centre, it's not likely to succeed, and what we need to do is to harness the enthusiasm that is so apparent when you talk to people on the ground for getting this right, and then I think we can crack it. I don't know if you want to...
Yeah, that's
Yeah.
okay.
I would like to and thank James for giving me the opportunity to just raise the question of the implementation of our recommendations. I mean, there is a lot in the report, as you will see, that asks various bodies and individuals, including Secretary of State, to respond on particular points. And I think for those of us who did the work, there is a real issue about implementation of some of those recommendations. And I believe from Secretary of State's officials that there is a plan that he will respond in more detail. He's only had the report for a relatively short time, and we're very much looking forward to seeing which of the recommendations he accepts. And also there's an overriding recommendation, which is that he might wish to report on the findings of our report in about a year. And I think that would give a lot of reassurance in the way that Secretary of State has described to the public, who I hope are seeing this as a positive development, but we were wanting to know how it's going to be taken forward. Thank you.
Christopher Finken, Chairman of the UK Council of Caldicott Guardians. I think Caldicott Guardians up and down the country are going to be jumping up and down with delight, or at least some of them will be. I think your expression of this being exciting is absolutely correct. I think it's pivotal. I don't think Dame Fiona's report, though, has just provided an intellectual framework. I think it's provided an ethical and a moral framework. And that is perhaps a sign of true wisdom. It's easier to recognise than to define. But my question is, and that kind of leads on from Dame Fiona's previous comment, is the devil's in the detail on all these things. Caldicott Guardians often have to deal with those grey areas which are not covered and recognise the needs of an individual patient that doesn't quite fit the rule. Things like your access to people having access to their GP records, great for the vast majority of people, but for people who are potentially subject to domestic violence and maybe under coercion, there needs to be safeguards in place. So how are you going to support Caldicott Guardians in this new world with these wonderful new things we've got to do? Thank you.
Comfort I can perhaps give Dame Fiona on this is that it's just not possible for this report to sit on the shelf and gather dust if we're going to make progress towards a paperless NHS by 2018, and that is a central objective. I've identified 4 core priorities as Secretary of State, and one of them is the paperless NHS technology agenda. And I know that in order to do that, we have to implement the things that you're talking about in this report. So we will be taking it forward very proactively. I think there are lots of things in here, as there were with the the Francis report into mid-staffs, which we will need to consider and take some time to work through and give a detailed response on. But we are absolutely accepting the spirit of what is being recommended here, and I think it represents a very good way forward.
Okay, well, many thanks.
Fiona and Jeremy to disappear, and then we'll carry on with our one-day conference. Can you join with me in thanking both of them, please? Thank you.
I will add that to my other major accreditation, the NC accredited half.